My word.
Tackle diabetes
I wanna-
because I'm hoping, I know that that's what Dr. Noel's gonna teach on Thursday. So he's gonna start, and I'm going to just tell you right here, so first off, I adore the man. I do, I think he's phenomenal. But anyway, he does the absolute best insulin lecture I've ever heard in my entire life. Okay, I'm just telling you, you will understand insulin in a way, and it's amazing, and I never understood it the way I did once I heard him teach it, and he does a great job. So we're gonna cover diabetes. Just kind of as a review, you know what hormones are, okay, and so, and, you know, our definition of hormone has expanded to include, you know, your typical classic endocrine. It also includes paracrines, your autocrines, your endocrines, and neuroendocrine. So, you know, I encourage you to review these concepts on your own. Okay, and so, you know, we have our classic endocrine organs, and we have our other non-classic endocrine organs. And so just take a look at some of that. Okay, as far as another summary, just as a reminder, you can review. Here is, and this is from your text, there is, you know, your selected hormones, and then what is their major action, and then their source. So looking at the hypothalamus, all the different hormones that the hypothalamus produces. Okay, you've got your anterior pituitary, posterior pituitary, and on down, and what they actually do, okay? And so this is a very good summary slide, and you can see that there's quite a few very highly active chemical compounds that are in our bodies that are released into the bloodstream or released into the tissues, into the marrow, as you know, and have their effect on other tissues. Structurally, the importance of the structural classifications, it has to do with some of the kind of crossover effects. So and as well as their half-lives in tissue and in the blood and in the tissues. Okay, and then also how they activate. Okay, so amines and amino acids, okay, these are typically derived from tyrosine. They include epinephrine, norepi, and your thyroid hormones. Okay, these are all derived from tyrosine. Okay, they're amines or amino acids, which tends to mean that they are they have shorter half-lives. Okay, they are more hydrophilic. Okay, and so your lipophilic, okay, and so your hydrophilic are going to require like transport molecules in some cases, especially in the bloodstream, and how they get into cells and how they're stored. So these are often stored in little, you know, your storage vesicles and then released upon stimulation. Steroids, on the other hand, they're not stored, and so they are manufactured at the time. So there is a difference in those as well. So if you look at your steroids, these are all derivatives of cholesterol. All of them are derivatives of cholesterol. So cholesterol is a necessary component in our bodies. And it's a necessary molecule for every cell and then for certain hormones. But that makes them lipophilic because they're derivatives of cholesterol. That's going to make them more lipophilic. So think about it. It's your androgens, your estrogens, your glucocorticoids, aldosterone. And then you have your peptides, proteins, glycoproteins. I know I'm jumping around a little bit. And so these are smaller peptides to all the way up to really large protein and polypeptides. Okay, and then your fatty acids, these include some of your icosanoids. And, so a subcategory of them are prostaglandins. So again, think about it in these kind of terms. So your protein based, stored in vesicles, released when stimulated. Okay, often in a pro-hormone form. Your cholesterol based, they're manufactured and released upon stimulation. Okay, and so the stimulation is, the timing of it is very, very different. Okay. Transport, it's either freely circulated or protein bound. Okay, and I flipped it. So your water soluble are gonna be freely circulated, like your norepinephrines, your peptides, things like that. They're freely. Your hydrophobics, because your blood's like 90% water. Your hydrophobic or your cholesterol base, your fatty acid base, they require protein binding. So this is why you're gonna have, you know, thyroid hormones are gonna be bound to protein molecules like albumin for transport. Okay, and the protein bonding actually extends their half-life. So your epi, your norepi, they're very, very short acting. So all your peptides, water solubles, short half-life. Okay, they get degraded by enzymes, they get eliminated through the kidney or the liver. Okay, a lot through the kidney. Your steroid hormones, however, they're carried to a target cell where they are taken up and then often stored or they have their effect. Right, and so that's why, you know, in postmenopausal women, okay, postmenopausal women who have larger fat depots, okay, more adipose tissue, their estrogen levels stay higher for longer periods of time, which tends to be more cardioprotective. Okay, and protective of the bones as well. Okay, as your estrogen levels drop in menopause, if you don't have the fat depots, the storage places for it, then it can be problematic. However, it can also be a source of cancer because if a woman still has a uterus, unopposed estrogen, right, unopposed estrogen can lead to endometrial cancer because of the endometrial proliferation without getting rid of it. Without the progesterone part, it's just going to keep proliferating and stimulate that endometrial lining and can lead to endometrial cancer. So fat depots, think about your hydrophobic, your cholesterol-based molecules, and with your protein-based, they tend to be hydrophilic, and so they're rapidly metabolized and eliminated. And then this just kind of categorizes them for you, the different classes, amines and amino acids. Yes, not, sure. There it goes. Okay. Sorry about that. So anyway, go back to my other way of doing this.
I'm tired.
What's that? Okay, now it works. Don't worry about it. So your peptides, proteins, glycoproteins, they make up a very large portion. Your steroid hormones and fatty acids. So. Okay, as far as mechanisms of action, you know, your receptors on your cells, okay, they're typically proteins, as you've seen for most other things. So they're the little protein rafts, the little protein molecules that sit on the surface of whatever the target cell is. And they can be inside in the cell membrane or inside the cells. They can be upregulated and downregulated. Okay, so if you're, you know, under low hormone states, your cells can upregulate these to try to get more. And then as they're constantly bathed in whatever the hormone is, they'll downregulate, okay, in high hormone states. Okay, and so, but the ultimate effect is in the cell nucleus itself, which, you know, takes over the production of the hormone or whatever the effect of the hormone is in that particular cell. So cell surface receptors, think about peptide hormones and catecholamines. Okay, and a lot of times these are going to, they bind and then trigger a secondary messenger within the cell for whatever the effect is. Okay, and think about, okay, epinephrine. Okay, epinephrine in the heart. Let's talk about your beta, let's talk about beta 2 cells in the heart. Okay. If epinephrine is released, it's going to stimulate, it's going to attach to these cells and then stimulate an increase in heart rate, which means it's going to increase its contraction. And so there's this secondary effect. For intracellular receptors, think about your lipid soluble, your steroid hormones. Okay, so they're actually going to pass through the cell membrane as opposed to attaching to the surface. And same thing with the nuclear membranes once they get inside the cell and where they're going to have their desired effect. Okay. There are a whole host of secondary messenger interactions. You know, there are intracellular between cells that act, so estrogens, etc. Okay. And so we'll go in, there are different mechanisms of actions of how these all work. I encourage you going back to AMS and reviewing some of this content. As far as the hypothalamic and pituitary, you know that there's a portal system between the hypothalamus and the pituitary. And so the hypothalamus produces multiple hormones. 2 of them are stored in the posterior pituitary and released when stimulated. And those are your vasopressin, your arginine vasopressin, also known as antidiuretic hormone. And what's the other one?
Oxytocin.
Right, oxytocin. Okay, and so those are produced and then stored in the posterior. Your anterior, there's specialized cells in the anterior pituitary, but they're under the control of releasing and inhibiting hormones from the hypothalamus. And so there's 6 of them. And so they will directly release them into the bloodstream, where they'll then circulate and have their desired effect in different places in the body. You know that there are positive and negative feedback loops. And so, you know, if the hypothalamus tells the anterior pituitary to release ACTH is going to be released. And then it's going to circulate and go to the adrenal glands and release, you know, in the particular hormones. And as those levels go up, then it's going to have a negative effect on the hypothalamus. So then it will shut off the stimulating hormone and potentially produce an inhibitory hormone to stop further release. Okay. There are neuronal inputs as well. Okay, so you've got hormone feedbacks, you've got neuronal inputs, so acetylcholine, dopamine, all, you know, norepinephrine, serotonin, all these can also stimulate the release of certain hormones. And then cytokines, especially your HPA axis and stress hormones like your glucocorticoids, those epinephrine, norepinephrine, again, cytokines can stimulate the release of these through the hypothalamus, and we see that. Okay. Your diagnostic tests, we've gone over those. There's blood tests, There's urine tests for catecholamine production. There's stimulation and suppression tests. Remember, stim tests are for hypofunction. Suppression tests are for hyperfunction. Your genetic tests, these tend to be very, very expensive. Imaging, again, it's very specified, depending if you suspect a lesion or not. So if you suspect a pituitary tumor or adenoma of sort, it's very specific. You're not doing a whole brain CT, you're only doing that particular area of the brain. But it's very specific. So that's just a quick overview, and what you don't remember, I encourage you to go back and review. Okay, I will go into some of the details with the specific disorders. And today we're going to start with glucose metabolism, so your diabetes. Okay. And as far as, the physiology review, as you eat, you're in the fed state. Okay, when you haven't eaten, you're in the fasting state. That makes sense. Yeah, we usually eat more than we need to. And that gets stored later, mostly as fats or carbohydrates. Your fats are stored in your fat cells, your carbohydrates get stored as glycogen in the liver, right? And so, in liver and muscle, and they can be tapped into later. Insulin itself, it's used to transport glucose into the cells. And so that's the main role of insulin. The main role is to, facilitate glucose transport into the cells, so the cells can then use it for an energy source to produce ATP. And let's see. So this diagram just kind of shows that as you eat, your glucose levels are going to go up. That's going to stimulate the beta cells in the pancreas. They have glucose receptors, so the blood that goes through the pancreas is going to say, okay, because the pancreas is not under hypothalamic or pituitary control, it's its own organ. It's going to directly sense the blood levels of glucose. And going to then produce and release insulin in response to it. Okay. And so insulin to then increase the glucose into the muscles, into the fat cells. Okay. It can be then put it into the liver and muscle for storage and storage. It depends on what's needed and where. Okay. And that's going to decrease your glucose level. And then the pancreas can stop secreting the insulin. So the insulin, it's beta cells in the islets of Langerhans in the pancreas. And so it actually gets secreted into the intracellular space, then passes into the bloodstream. As far as at the cellular level, it's going to interact with insulin receptors that are on the surface of cells. That stimulates the GLUT4 transporter in muscle cells. So, some cells don't need the insulin to get the glucose into the cells, but your muscle and liver, they rely on certain receptor types to then transport the glucose into the cell. And so that's going to then be either utilized, stored as glycogen or fat. And insulin also suppresses enzymes that break it down. And so otherwise, without insulin, the process is much too rapid. It's too quick. So it does suppress some of the enzymes. So this just kind of, again, actions, it's going to, insulin is going to store promote the storage of glucose as triglycerides and glycogen. It actually decreases when you have plenty of glucose. You don't need to manufacture your own glucose because it's there, it's available. And so it's going to decrease gluconeogenesis when you have higher levels of glucose. And it's going to increase glycolysis. That's what insulin does for glucose. Fatty acids, the insulin's going to increase storage of fatty acids. Your insulin's going to decrease breakdown of lipids. And so it's going to, use the glucose that's available. As far as amino acids, insulin will increase amino acid uptake, which is important for our protein building blocks. It's going to increase protein synthesis, and it's going to decrease protein degradation, right? Especially in those muscle cells. And then as far as potassium, it's going to increase your sodium potassium activity. And so increase your uptake of potassium, cellular potassium. Okay, so it's gonna the insulin's gonna drive potassium into the cell. This becomes important when you have DKA, okay, or hyperkalemia. So we can use insulin to lower serum potassium levels by driving it into the cells, facilitating its passage into cells. So insulin has a lot of different functions. And so, but if you look at this, if somebody lacks insulin, go through each of these and see what happens. And so if somebody is not producing insulin, okay, they're type 1 diabetic, they're not producing insulin. Okay, what's going to happen with their potassium levels? That's right, potassium's going to go up. You expect hyperkalemia. Okay, what's going to happen to the glucose? Okay. And so it's not going to be stored, it's going to be circulating. So the glucose levels in the blood go up, you can't store it. Okay. And so the cells are being deprived of glucose. So then what do? Yeah, well, it's going to stimulate gluconeogenesis. And so in addition to having high glucose levels already, with the lack of insulin, it's going to promote gluconeogenesis, which is going to add insult to injury and raise those glucose levels. Your fatty acids, instead of storing them, they become the major substrate for energy. Okay? So lipolysis increases as storage decreases. And what do you think the metabolic byproduct of fatty acid metabolism is? Ketones, keto acids. That's the metabolic byproduct. Now let's look at the amino acids, which are important for protein synthesis. If you're not able to get proteins into the cells, and let's talk specifically about muscle cells, what happens? Start breaking down your proteins too. To release amino acids, because amino acids and fatty acids can be used for gluconeogenesis. Okay. And so even though your type 1 diabetics who are not producing insulin, their beta cells are shot, they're not producing insulin. They're skinny. they have muscle wasting, but their sugars are so high. Their glucose levels are off the chart. But it can't get into the cells, so the cells start to break down. The fats, the muscle. For alternative energy sources. And they become hyperkalemic. And quite, they develop keto acids, then they become acid eating. So remember, gluconeogenesis from glycerol, fat breakdown, proteins, okay? And this becomes another important source of your hyperglycemia. It's not just no insulin and the glucose not going into the cells. Gluconeogenesis is gonna respond by increasing, adding insult to injury and increasing your glucose levels. Okay. So that's your review of physiology. Okay. Liver, glycogen stores, you break down glycolysis, you release glucose. That's going to raise your blood sugar. Your pancreas produces both insulin and glucagon, beta cells, alpha cells, respectively. Glucagon in your fasting state to break down and release glucose. Your insulin in your fed state to then facilitate glucose storage as well as glucose metabolism in the cells. Now, type 1 diabetes. About 10% of all your diabetics are type 1. Okay, tends to occur earlier in life. And this is an autoimmune process that destroys the beta cells. We don't typically see full-blown diabetes until at least 80% of your beta cells have been destroyed. So it's very far along in the autoimmune destruction when we start to see signs and symptoms of diabetes. Oftentimes there's genetic susceptibility, but there are also environmental factors. There are a small percentage who are considered type 1B, where there's been no evidence of autoimmune destruction, and it just seems to be idiopathic. We don't know what caused the shutdown of your beta cells. Okay. And so in those patients, insulin resistance and a reduced secretion is going to play a role. So what are your genetic factors in type 1 diabetes? Okay. The genetics, there are a multitude of cases. I mean, the majority, really probably a lot of this big significant portion of them, people who develop type 1 diabetes, kids who develop it, nobody in the family has diabetes, type 1 diabetes. Okay, so it can present when there's no family history whatsoever. Only about 10 to 15% will have a first or second degree relative with type 1 diabetes. So the majority of them, there is no family history. There are predisposing genetic locations. There's multiple. It's not one particular site, but there does seem to be a significant portion of them on chromosome 6. And there are some polymorphisms in the insulin gene promoter. So there's multiple reasons for it. Okay. And yes, other genetic associations. So can I pinpoint it to one? No. Okay. So that will not be a test question. Environmental factors. Yeah, we know that a lot of these cases occur after a viral infection, especially in kids. Early on, they get a virus, and all of a sudden, after the viral infection, now they're diabetic. So could it be that, much like oncogenes, that these viruses, trigger a genetic aberration or a predisposition, lead to, in fact, to the destruction of the beta cells? Absolutely. Toxins. And there's also evidence that cow's milk and cereals in certain individuals, it's not across the board, but there's evidence that supports it to some degree. But typically the disease progression is over time. And again, in the first part, patients are actually asymptomatic. They have to have, I'll say again, at least 80% cell destruction, beta cell destruction. Yes.
It says cereals in there too.
Yeah,
What kind of cereal?
I don't know. I don't know.
Your
I
Honey
don't
Nut
know.
Cheerios aren't safe.
I've seen all kinds of things being thrown out there. And the problem is, it's the study type. And they look for patterns, and they're all retrospective. There's a lot of subjectivity. And so I leave it at that. Okay. I mean, this is not something ethical that we could say, okay, let's do this and take 16 kids or 25 kids or 100 kids and let's give them all cow's milk and see how many of them become diabetic. Not really ethical, never pass an IRB, okay? So, I hedge on, I'm one of those people that I really kind of like to really read into, okay, how good is this study designed? So, but the progression, okay, you start somewhere. If you have a relative, okay, you have a 10 to 15% higher risk starting off. Okay? But that doesn't mean that you are going to develop it. Okay, something triggers this or activates this autoimmune kind of destruction of the beta cells. And so, yeah, does it make sense that it's an some kind of relationship to an MHC molecule on a human leukocyte? Yeah, it does, because the leukocytes are programmed to attack certain antigens. And so if there's an antigen or a protein or some kind of glycoprotein on the beta cell and it becomes stimulated, or there's a likeness, some type of molecular mimicry, then the white blood cell could attack those particular cells and destroy them because it senses them as being foreign. So immune activation. Over time, destruction, okay? Because you've got this immune response now. Okay? And even in the early stages, you can still have normal blood sugars. And it's only until later that you'll start to see abnormal blood sugars. And then clinical diagnosis occurs even further, because it doesn't happen overnight that all your beta cells are destroyed. It is a progressive destruction. And then once they're destroyed, then you're going to have long-standing type 1 diabetes, because your beta cells are no longer capable. You don't have them, or they're no longer capable of producing insulin. So we have to give exogenous insulin. Does that make sense to everyone? Yes, Dave.
Are those autoantibodies, are they present in all diabetic everyone, like type 1 diabetics?
Well, not all, because we said that a certain number are idiopathic, about 10% are idiopathic, and there's no autoantibodies. Is it just a genetic mutation? We don't know yet. Right?
But then in the other ones, even if it's like toxin related or virus related, they can develop the autoantibodies.
Yes, 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 absolutely. And we don't have, like, we haven't been able to like identify or watch this whole process occur, so. A lot of this is theoretical and this is what we noted. How it all works, we don't know. Okay. So there are 3 forms, the most common. Often comes on when there's this pre-adolescent growth spurt. So pre-adolescent, age range. One, you diabetes. So 8 to 7, 8, 9, 10 years old, somewhere in there sometimes, right before they get that growth spurt. Okay, before they go into their adolescent years. If they're still children. And that's the most common. It tends to be slow to come on. And usually a lot of times there are associations with other autoimmune diseases. Okay. As far as one of the other ones is the younger children, even younger, like 6-year-olds, 3-year-olds. And it comes on very, very quickly. This is the one I described, usually after a viral infection. And it happens very fast. Now, there's another form that occurs in adults later on. Used to be called LADA, L-A-D-A, latent autoimmune diabetes in adults. Now they also call it type 1.5. Okay. So, I like latent autoimmune diabetes in adults because it's very descriptive. Okay, it tells you, okay, usually these patients we even start as type 2 diabetics. And then they end up with autoimmune destruction of their beta cells. So, and we'll talk about type 2, which is insulin resistance and abnormal production. But then they develop autoantibodies and they still end up with destruction of the pancreatic beta cells. So, yeah, it could be this autoantibody of glutamic acid decarboxylase. So it targets that, which then destroys that part of the cycle. Okay. Either way, in all 3 of these forms, whether it's the very young, it's the kind of pre-adolescent, or it's the older adult, the common denominator is destruction of your beta cells, and usually by T lymphocytes. And they're no longer able to produce insulin, which means they require insulin. And these patients are going to require insulin for the duration of their lives unless they get a pancreas transplant. The absolute deficiency is going to completely result in failure of all of those anabolic processes. So all of the storage, all of the etc. As I said, glucose can't get into the cells. It's going to build up in the bloodstream. So you're going to have hyperglycemia. Okay. Now you've got large molecules in the bloodstream that's going to increase your osmolality. High osmolality by the hypothalamus is going to lead to what?
pH release.
Increased thirst. Polydipsia. Okay. Also going to be filtered into the renal tubules where it's going to increase osmolality. So it's going to lead to polyuria. Okay, because water's going to stay in with it. Okay, water's gonna, osmose into the higher solute concentration. So you're gonna have polyuria, you're gonna have polydipsia. Water losses, your body's trying to compensate. Your cells are starving because the glucose isn't getting into the cells. So your cells are telling your brain, I'm hungry. Eat, Papa, eat. That was from Rudolph Brendan's right here. So, go back. This is pause. Eat, Papa, eat. She wanted him to fatten up. Anyway. I'm talking to my child. It's okay. So, yeah, cells aren't getting any glucose, so they're saying, feed me. So polyphagia. The cells are breaking down. They're not getting glucose. They're starving. They're breaking down everything they have, and so ultimately, they start catabolizing themselves. It's going to lead to irreversible cell damage, cell death. You're gonna have weight loss. You're gonna have muscle mass loss. You're gonna have fat storage loss. Okay. And all this alternative using, fatty acids for metabolism and breaking down your protein stores is going to lead to ketones, keto acids, and this is how patients end up with diabetic ketoacidosis. So you get lots of acid production. Your keto acids, because that's the fatty acids become the alternative food source. Breakdown products, ketones, keto acids. The Simoji effect and the dawn phenomenon. So this is in your learning objectives. So Simoji effect was initially proposed back in the 1930s. Well, this is well before modern medicine. This is almost 100 years ago. And this Hungarian physician, whose last name happened to be Simoji, that's how I got the name, proposed that, okay, he would see this early morning hyperglycemia in diabetics, specifically your type 1s. Okay. And so he proposed that it was due to a rebound hyperglycemia because of counter-regulatory hormones. So in the non-fed state, okay, and they go to bed and they don't eat, so their glucose levels drop because of insulin, et cetera, if they're being given it. So their glucose levels are going to drop. But then the stress hormones kick in. And that is going to release some of the gluconeogenesis, release some of your glycogen stores, your glucagon, et cetera. And that's going to raise your blood sugar. So that would cause an early morning hyperglycemia. Okay. The more recent studies say that this is probably not reality. Okay. It was a good theory back then, but it's probably not reality. It's less likely. The dawn phenomena is more likely. Okay. And the difference is both of them are explaining the early morning hyperglycemia. However, the dawn phenomena says there doesn't have to be hypoglycemia overnight for there to be hyperglycemia. And so it's just because of decreased insulin production at night that you're going to see hyperglycemia. And so what they've been able to track, and this is just by taking blood samples, is that your insulin secretion pattern follows its own circadian rhythm. It's opposite melatonin. Okay, so whereas melatonin is secreted mostly at night, its rates are high between 12 and midnight and 6 a.m. Well, that's when insulin's the lowest. And so and so as those levels drop, as a result, you're going to see a increase in your glucose levels, and patients will become, their early morning levels they'll be hyperglycemic. And that's just their normal circadian rhythms. And so there is typically an early morning spike of insulin in normal healthy people that prevents this phenomenon of hyperglycemia in the morning. But because your diabetic patients lose their ability to produce insulin, and even in your type 2, so as they lose that insulin production and they're not able to produce that spike, then you're going to see a hyperglycemia in the morning. In type 2s, it's the insulin resistance. And it tends to lead to constant high glucose levels at all times of the day and night. All right, so what questions do you have for type 1 diabetes? Yes, go ahead.
Is this kind of why, like, the highest levels peak between 12 and 6? Is this kind of why they tell you not to eat like a big dinner at like 8 or 9 o'clock, or is that?
Yes.
Because of,
Yes. They do tell diabetics that your biggest meal of the day is better to have it when?
like lunchtime?
Uh-huh.
Yeah.
Why? Because your insulin levels, what insulin you have is going to, the highest peak is between 12 p.m. noon and 6 p.m. So that's when your body's gonna naturally metabolize what you can. And so big meals in the evening are typically bad because of that insulin, that circadian rhythm and the insulin decrease overall.
Yeah, so it'll like worsen the hyperglycemia in the
Correct.
I'm wondering how this is affecting some of those like night shifts or rotating shifts.
You know, it's a really good question, and, my answer to that is, I believe it's the stress hormones, those counter-regulatory hormones, that play a role in that. Okay, your epinephrine, norepinephrine, that are going to stimulate, your increase in cortisol levels, which then increases your glucose. Yes, Abel.
Was the melatonin comment just like an interesting fact, or is it like they control each other?
I don't know that they found a specific relationship between the two.
But there seems like there kind of seems to be.
There seems to be this, yes, there seems to be that these are opposite each other, which, it's kind of one of those stay tuned.
Right.
Because remember, it wasn't that long ago that people thought the pineal gland was just a vestigial organ and did nothing. And now they know that it secretes melatonin, which is important in our sleep-wake cycles. So stay tuned. Still lots more to find out. It's gonna be interesting what they find out now that they, with technology and all. Yeah, Cindy.
You said one of the only ways that a type 1 could ever not need insulin is with a pancreas transplant, but wouldn't the autoantibodies just attack the B cells in the new pancreas?
That's a very good question. And yes, in some cases, if you look up how long pancreatic transplants typically last, they're not very long.
Okay.
They're not very long as a general rule.
Okay.
And so it is possible.
Okay.
Yeah.
Is there anything that's like reversal? Steroids or something? At the patient to start, if you had five.
We don't know. I don't know that any of those studies have been done. It would be interesting to do a search. But it's, you know, you've got to be so careful because of all of the bad effects of steroids that I don't know that they can justify the use of them and how do you select your patients? Because you just don't know. You don't want to be giving every child steroids every time they have a viral infection.
So like in these patients, it does seem like very much as a viral infection that every person.
Not to my knowledge, I've never said like, because usually what's gonna happen in these kids is that they just have like a normal upper respiratory, they might go to the doctor, might not, you know? And then all of a sudden, then the kid becomes lethargic and tachypnic and parents, like, they're over the virus. The virus was like a week or so, 10 days or 2 weeks ago. And the kid's back to normal, and all of a sudden the kid tanks. And they're like, and they rush them to the emergency room and their glucose level's like 1200. And they're in DKA. At that point, they're done. There is no reversal. Question? How, be specific, I mean,
I know this from part.
don't know. Don't know, she could be one of those idiopathic people. We don't necessarily know. It's not your typical pre-pubertal growth spurt. I know that when I was doing, back in the day when I was doing like pre-school physicals and things like that, you know, screenings and stuff like that. You know, like just a routine urinalysis, I'm like, this kid's got glucosuria. This isn't normal and no history, no nothing. Like, you gotta get this, you gotta go in to see your doctor because this could be done. This is it's happening. That was like 16. You know, 15 and 16. So it's past that. Well, we talk about means and averages, and so there's always a spectrum. Don't know. Don't know. Sure.
I think that's what about why I'm
Okay, sure. So
probably that I have.
polydipsia. Okay, so glucose is a really big molecule, right? So it's going to, and when you're used to having so much in your bloodstream, it adds a certain osmolality. It is a solute in a solution. So when you have high levels of glucose, what's that going to do to your, that means you have high solutes in solution, right? So what's that going to do to your osmolality? It does, it pulls water in, but it also tells the brain what? I'm thirsty, right? That's how you get water in. So one of the normal response is to a hyperosmolar solution or hyperosmolality is increased thirst, polydipsia. But there's also the other side of that, in that at about 160 to 180 is when your proximal tubules can no longer resorb glucose out of the nephron. And so as it goes through the loop ahead, where normal osmotic water shifts occur, you're going to have large molecules and higher osmolality there. So that's going to draw more water in to the nephron, into the tubule for urination. So you're going to be polyuria and getting rid of water And that's gonna compound the already high osmolality of polydip, and which is triggering polydipsia. So now you're drinking, your sugar's high, you're urinating, and it becomes a cycle. And the fact that your cells are not getting glucose and having to rely on other means equates to starvation. My cells are starving. Eat, eat, eat. That's the polyphagia. Does that help?
Yeah, it's just a big molecule and it's water.
It pulls water into the nephron for excretion, so you're losing water with sugar. But at the same time, that's leaving high concentrations of sugar, high osmolality in the blood that the brain is sensing as thirst. I need more water. I need water. Yes, you got it. Now,
So, okay, the beta cells are destroyed, and then do they not have any insulin at all?
at some point, there is no insulin at all, yes.
Okay, so why do we care about this occasion?
Because people are on. They can still have 20%. So when they start becoming symptomatic is when 80% is destroyed. They may still have some insulin. So you may see these kind of shifts before they become beta cell deficient, completely 100% beta cell deficient. Okay? Yeah. It's during that, remember, this is a long progressive destruction for most patients. Any other questions? So what do we have to treat them with? Insulin. All right, and I'll stop here on my lecture, but I'm going to ask you. So what kind of insulin do you think would best mimic the body's kind of normal, whoa. Like, long acting, yeah. The really long acting stuff. So, you know, you're gonna learn on Thursday that basal insulin, and if you go back to your, I know you all hated the PCA pump, but you had a basal rate of pain control medication, okay? So it's like this constant drip across a long period of time. Well, basal insulin kind of mimics the body's normal circadian rhythm and is long acting. And so the longer one is going to give the patient the best control long term. Then all you have to account for is what? Meals. So that's type 1 diabetes in a nutshell. Okay, that's type 1 diabetes in a nutshell. So you get real short acting to account for meals. You got the long acting to account for everything else, and you're good. That's type 1 diabetes.